Ay, Carlos, si quieres dile a las personas que vengan. Okay. There you go. Hola. Hi. Perfect. Hello, everybody, and thank you so much for coming to this breakout session. My name is Mara Echevarria. I am the clinical director for DigiMed, and I am a nurse also. As I said before, we at DigiMed are a digital service company that we help providers and medical facilities such as hospitals, independent providers, and federally qualified health centers use programs like CCM and RPM to enhance patients' life. So today, I am very excited to share with you results, actual results of programs that have been established here at USVI. So I don't know, I don't have a clicker. Okay. So what if I told you that you can really reduce costs, but at the same time gain significant benefits, not only for your patients, but for your providers also? And also, what if I told you that you can access more patients anytime and anywhere, especially by relieving stress to your staff? And that is very important here in the Caribbean, because we are usually under surveillance of tropical storms, hurricanes, and now heat waves. But the most important factor is that you can truly educate, engage, and empower your patients on taking control of their chronic disease. And that's why we're here. I don't have a clicker, so everything is possible, moving from a fee-for-service model to a value-based model. And actually what that means is basically implementing a model that can truly measure quality of patient care, and that's, the most important. You can do that by establishing programs like CCM and RPM. CCM, it's very important, and actually patients do like it a lot because it's a monthly call, and they receive that monthly call just reviewing a care plan that has already been approved by their medical doctor. And basically, we serve as health coaches and encourage those patients to get their medication, go to their appointments. And RPM, remote patient monitoring, well then RPM uses digital data, specific biometrics from that patient. And this is very important because you receive that data just to prevent any at-risk event. And usually what you can track is vital signs such as blood pressure and pulse, which are the most popular, glucose levels, oxygen levels, weight, and so on, because technology changes every day. So every day you get more tools that you can help track that patient. So if I can put all this in one mathematical equation, basically it will be case management plus monitoring plus transmission. Definitely you're gonna have guided care. And guided care, I believe as a nurse, should be a standard of care in all medical facilities, and is the future of healthcare after, all these pandemics and all these issues surrounding us. Next, please. So when we take an overview of the USVI island, we have roughly 87,000 citizens, which is the total population according to the 2020 census. And out of those 87,000, we have 38,000 citizens between the ages of 50 and 85. And it's quite impressive because it's quite a chunk of people that are in an aging population, which puts them in risk, direct risk of developing chronic or multiple chronic diseases. So out of those 38,000, we have 30% of them already with a hypertensive diagnosis. And out of all those population, out of the whole chunk of hypertensive patients, we have 45% under the category of uncontrolled hypertension. Now, this is a big red flag right here because almost you have 50% of the hypertensive patients already being under the category of uncontrolled. And an uncontrolled patient is that patient that constantly, their blood pressure is constantly above 140/90. And of course, at this point, usually they're with other, combined with other chronic diseases such as diabetes or renal failure. So basically, it's like a walking ticking bomb. So it's very important for us to identify these patients, and the most important, give them the tools, the necessary tools and the coaching to help them know how to treat their conditions and to have them control. And this is why we wanted to test actually the RPM and the CCM program. Next, please. So what we wanted to do is, I was like, okay, I'm a nurse. I really want to see if if these programs work, and they do work. What we measured was program adherence, very important because adherence means that the patient follows the treatment as the provider indicated. We also measure the effectiveness in hitting and staying in that target range, which is the healthy range that you want to have your patient or most of your patients. And lastly, we measure patient engagement, which is of course the measurement to know that your patient understood and now has the tools to take control of their disease. Next, please. In program adherence, what we have is that this part of the story shows that 70% of participants demonstrated a very high adherence to RPM in 4 consecutive months. You see, at the beginning of the evaluation period, which started last year in January, the average patient's health blood pressure was around 139/74. So as months went by and the patient was in the program, answering the calls, taking their blood pressure, you can see in the blue line how their blood pressure started dropping, and at the end of the evaluation period, we have patients that drop up to 4 points in their blood pressure measurement, meaning in their systolic and diastolic. And that was only with RPM, no medication. So this is an important finding because it truly validates that if you have someone coaching you, taking you with you during this journey, it really works. On the orange line, we see the patients that, of course, are not adherents, and that is a reality. Not all the patients are gonna behave well. So we see that although on average their blood pressure was a little bit more controlled than the blue sample, since they were not adherents, of course, the disease is going to take their natural course, which is, to get worse. That's why you see that line going up. And instead of dropping points on their blood pressure, they started increasing points in their blood pressure. So program adherence really works. We see it right here in these patients. But then we wanted to go further, and we wanted to really test the effectiveness. Next, please. And in this slide, we test the effectiveness of the patient staying in the desired target range. And we divide our ranges in target, which is the ideal, critical, which is going 10% to 50% above or below target blood pressure measurement, and the critical in red, which goes 15 to 20 plus above the target range. The idea is to maintain the most patients in the target range. So at the beginning of the evaluation period, we have almost 50% patients in the target and 47% in at risk. And this is working with a sample of 270 patients from USVI islands and a little bit of them from Puerto Rico. But basically, these are patients from independent clinics, a renal clinic, and a federally qualified health center. So as months went by and patients were adhering to the program and taking their blood pressure, we see how quickly we have patients in critical and at-risk ranges dropping and moving to the target range. So at the end of the evaluation period, almost 5 to 6 months later, we were so happy to see that 70% of these patients were and stayed in the target range, which is having constantly your blood pressure between 110 over 80, over 90. So this is a very significant finding because then again, it truly works when the patient has a health coach side by side, knowing that if something happens to you, you can reach out and you can have you have that person. Also, this is an important finding for the providers because usually as our system is established, the patient goes to the visit and probably the provider doesn't see that patient in like 6 to 9 months, and you don't actually know what the patient does at home. So now the provider has visibility, with all this information that we gather and we share with them. So I am very happy to share this information with you. Actually, we have patients that they graduate from the program because they learn and they have all the skills and tools that they need to manage their control. So that's a good news because new patients can come in. Next, please. And when we evaluated the CCM program, CCM, of course, doesn't transmit data as RPM does, but CCM is very important because when you're managing a CCM program, you are constantly on a monthly basis evaluating the care plan of the patients, and you truly have a taste of the social determinants of that person at home. So that's why usually they don't comply with their treatment. But we're happy to say that 95% of patients here at USVI are in compliance with the program. They do enjoy having someone calling them on a monthly basis, like they say, checking on me or checking. That is very important because some of these patients, they're here by themselves. Their relatives, maybe they live in Puerto Rico or in the mainland. So they feel that someone is taking care of them. So basically, to have a roughly idea, we generate more than 300 calls a month to follow up on these patients, and this is only the USVI accounts. And on average, it's like a 23-minute call. So that gives you an idea that it's truly a call that you get to listen to your patient and follow that patient, and very important, you have time to educate your patient and validate any doubts that they have. Basically, the patients do really need help scheduling appointments, and it's very important to help them have that appointment scheduled, because if not, they're not gonna go, they're gonna miss it, and probably the provider won't see that patient probably like in the next year, or maybe when that patient hits the hospital, and then you have a higher cost right there. So 40% of those calls is just related to appointment scheduling, and 60% of the calls that we generate for USVI are just helping those patients get their medication, get their refill, and how, the correct way to take that medication. Next, please. And just wrapping this up, the final look, of course, CCM and RPM are Medicare programs. Medicare established the way it should be established, for the patient. But the good thing and the advantage that USVI has over Puerto Rico is that CCM program has reimbursement here. So that is the biggest barrier that we have in Puerto Rico with this program is that it's not reimbursed. So usually the patient has to pay for it. Some they do, some private insurance do, but not Medicare or Medicaid. So this is a big blessing, like I said, that USVI has with the CCM program, that you have to have your patient, you have to use it on patient that has 2 or more chronic conditions, and of course that patient at least has to visit their doctor once in the past 12 months. So the next slide is a workflow of CCN, so that gives you an idea at the beginning when you're implementing a program like this. You know, it may seem like it's a lot of steps, but once you get the hold of it, you know, it's very easy to implement. The most important thing is to identify the patients, identify the chronic condition that you want to work on, that your providers want to work with, because probably you as an administrator want to work with glucose because you have a lot of diabetic patients, but truly your providers really want to work with hypertensive. So identify eligible patients that have 2 or more chronic conditions is the step 1. And also, it's very important that that patient knows that they have that chronic conditions, because sometimes when we call them, they're like, no, I am not hypertensive. Why are you calling me? My doctor has never said that to me. So, you know, those are, you know, the missing links that usually are in healthcare. Programs like this help to engage with all those missing links. So, and the third most important thing is having consent from your patient. Your patient has to consent to be part of this. Once you have consent, the medical provider approves the care plans for the conditions that we're going to work on, and then, you know, the care management begins and the magic happens, and on a monthly basis we'll be sharing those outcomes with the care team of that clinic. On the other hand, next slide, RPM has also reimbursement. I'm not sure, Carlos, I'm not sure if for USVI has. Yes, also for USVI, so that's a double whammy. Puerto Rico, we don't have that. Patients are dying to have it because this is the fun program. They have a device, so they get a device, and they really enjoy having that device that connects directly to their provider. So RPM has reimbursement. I'm sharing here with you the 2023 CMS RPM reimbursement rates. Please keep in mind that in some regions, you know, the reimbursement rate may vary, but usually this gives you an idea of, once you implement this program, the reimbursement that you can have. Next slide, please. Here I'm sharing with you the workflow for implementing RPM program. You can implement it in a small office, in a clinic, in a hospital, in a federally qualified health center. It doesn't matter. The most important thing is just, once again, identifying your patient that truly has the condition. And in this case, the patient really needs to understand technology, because if the patient doesn't feel comfortable with the technology, like some of the patients manifest, you know, they're scared of the device. They may think that someone is tracking them through the device. I will recommend that's not truly the ideal patient. So just try to keep in mind that it's part to be, you know, enrolled in to have a successful program, and then of course have successful outcomes. You have a patient that truly understands a little bit of technology. So once you have that, of course, the patient has to have consent, and then the education part starts with educating the patient on the device, on troubleshootings, on management of the device. And once starts transmitting any data, then we just, you know, like they say, put the ball rolling and start managing that patient according to the doctor's protocols. And this is, you know, where the target ranges and the critical ranges come, and, you know, the protocol, if after 3 or or 3 critical readings, then we call the doctor. Because remember, RPM is not an emergency management program. It's a preventive. So we are those eyes way before the storm, just, flagging things, but the provider has to take action. So the good thing is that we are those eyes that help the providers know way beyond, like I said, the disaster comes. Next slide, please. So very important, what we recommend? Well, we recommend the increased use of these programs here in USVI, CCM, and RPM. Ideally, will be in all healthcare facilities because, as you saw, truly helps patients, and especially patients like me that I live in an island. So everything needs to be brought to me, and I know what it's like to wait 6-9 months for your appointment. So our recommendation is that more healthcare facility adopt these programs and they establish these programs, as well as training to providers. It's very important that the providers, they know they have these extra tools, because after all the pandemic, and usually we hear providers, manifesting, oh, we don't have enough help, or this and that. These programs are already established, and they do work. We just, need to let them know that they are available. And the most important thing is let the patients know that they also have these tools and they're available. And so they can, some of these patients, especially diabetics or hypertensive patients, they don't have a device at home to do home monitoring because they think they have to pay it themselves. So some of these programs help those patients get those devices for them. So any questions? Yes, Miss Michelle. Oh.
Thank you. One of the questions I get from the providers is how they get around Medicaid not covering this, and then what should their communication to their patients be? So I'm just wondering your thoughts on.
Yes, that's an excellent question. I'm gonna leave you with Carlos, who is the expert on that reimbursement part. I am the nurse, the clinical one.
So thank you for your question, Michelle. We were able to have a conversation with the Department of Health Services here in the Virgin Islands, and the MAP claims supervisor was able to confirm that they will in fact be reimbursing for these programs after the public health emergency, and they will be honoring the same rate that CMS established for the Virgin Islands at a national level. So that is a huge accomplishment, and as Mara was mentioning, it's an advantage that the Virgin Islands has not only over Puerto Rico, but also over a lot of states in the mainland that do not have any type of reimbursement for these programs. Because, to be quite frank, the technology is out there. However, regardless of how beautiful it is, it has a cost. And this is a program that over the surface looks simple, but it requires a lot of components to work together in order to turn the wheel in the direction that you want it to move, which is better clinical outcomes for those patients, better chronic disease management, more revenue for the facility, and also a reduction in the cost of care of these patients. So one of our latest campaigns has been to educate the providers here in the health facilities of that advantage that they have and how they can leverage those reimbursements to dive into these technologies, which will not only allow them to sustain a healthy operation from a financial standpoint, but also allow them to tackle issues such as physician burnout, such as patient triaging, which can be quite complex when you don't have that visibility between visits. Thank you for your question.
Excellent question.
I'm going to follow that up, so don't go too far because you'll need the mic to respond. But one, I would say that is great news, and and RPM?
So the answer is yes. It's both for CCM and RPM, and you have to look at which facility is interested in embarking on this journey of digital health solutions, because the CPTs can vary depending on the health facility. For example, the CPTs that you saw in the presentation are more for individual practices, whether it's a primary care provider or a specialist. But then you have another point of care, such as a federal qualified health center, who has a whole nother billing code for these same programs. And the answer is yes. They also have a reimbursement both at a federal and local level.
Okay. So the only other thing I would say is I think that, I work with Director Smith. I think that's great news that needs to go out to like the Medicaid providers, those
definitely.
in the program. And my encouragement would be to work with him to get that
Yes.
that word out to those providers. There's a talk about the public health expiring, the PHE expiring, and confusion about what that will mean. So I think this is a good education point,
It
and
is.
this is timely. So thank you.
Thank you. Is there another question or? Right.
When did you say that Medicaid will start reimbursing for these codes? I know it's related to the end of the PHE, but do we know like what that means?
So they were actually reimbursing during the PHE because CMS waived a lot of the requirements and was just more focused on allowing healthcare organizations to continue providing services regardless of whether or not the patient was in the clinical setting. And this allowed health organizations to keep that utilization up during the health emergency. After the PHE, which I'm guessing already expired, if I'm not mistaken, they will continue to reimburse for it, and the rates are honored at the 2023 physician fee schedule up until the end of the year.
What happens at the end of the year?
You would have to contact the Medicaid
Oh,
office
they're
in the
just
U.S.
whatever
Virgin
the new
Islands.
rate is going to be then.
Whatever the new rate or whatever change might happen
Right.
in terms of policy at a local level.
Okay, I got you.
I think there's another question.
A segue to my question. As a taxpayer and as someone that would want as much money as possible to be used on patient care, improving the patient's journey, what is the difference in terms of expense for the system of a patient that's uncontrolled and not controlled? And if you have an idea of, with this number of patients, if you can extrapolate how much money could be saved in the USVI to help reduce the probability of a negative change from CMS and
Yes.
improving this type of care so that there's more money for other conditions.
Yes, excellent question. Certainly, an uncontrolled patient means in rice and beans, it's a patient that is gonna use more medication, probably or certainly will use more the ER constantly, because every time some complication happens that their provider doesn't know, the patient's gonna go to the ER. So then you have the typical ER situation that when the truly emergency comes, the ER is so packed with actually preventive cases. So these programs, I believe, should be a standard of care in the near future, because this is the future of healthcare. We have to start moving from the fee for service model to a value-based model where truly quality gives you patient improvement and at the same time really reduces the risk and the cost. So promoting self-monitoring programs like this one with home base, like right now our system is designed to have these programs at a hospital level. but it's not working. It's too much money to keep up with such an, operation like that. So we need to start moving to a at home, a medical home base, and this is the perfect programs, the CCM and RPM, that I believe should be implemented both at the same time with the patient, especially a patient with multiple chronic diseases such as diabetes, hypertension, and hyperlipidemia. That is, the perfect factors for the perfect hurricane storm. So answering your question, I believe that this is the way that we can, truly reduce cost medications, ER visits, and I'm not gonna enter with other complications that usually patients like this have, such as dialysis.
If I may add to your answer, Mara, that's a great question, and at the end of the day, it's a collective effort. So right now we have a fee-for-service model here in the Virgin Islands, so it serves as a cushion for practices that need additional revenue to fund their operations. But the only way to truly prove and demonstrate with hard evidence that this program here in the Virgin Islands, regardless of the social determinants of health that are prevalent in the territory, is to create a use case. And to create a use case, we need help from all stakeholders in this island so that we can effectively share data and measure utilization of patients before they were in the program and after they were in the program. Because you have two types of utilization. The one that you want to foster is primary care utilization because it's a preventive utilization and it's far less costly than reactive utilization, which is I don't have access to healthcare. I don't have anyone I can talk to. I don't have anyone who's educating me. I don't have anyone who's engaging me and empowering me to take control of my health. Therefore, I'm going to go to the emergency room, or I'm going to go to the hospital, or I'm going to take this medication, assuming that this is how I should take it. So we invite all stakeholders in the government and in the private sector here in the Virgin Islands to create a use case so that we can demonstrate that regardless of how challenging it can be to adopt these new technologies, it is possible. We just have to get our heads together. We need, obviously, support from the government and from the Office of Health Information Technology in terms of funding and in terms of accessibility of these programs. And the most important part is education. We can have all the technology in the world, and it's out there. That's my biggest takeaway from this convention. However, it's important to hear from the people who will be using that technology, from the people who on a daily basis show up in the office and have to deal with all of these challenges. And they're the ones that we have to listen to and bring them on board on this project so that we can show them that you're not on your own. We can help you and technology is here to stay. So that's my answer to your question. We need a use case, and for that we need data, and in order to prove that data we need communication between everyone.
Okay, so is there another question? I think we're fine. So wrapping this up, basically, we are the bridge. We serve as a bridge between the providers and the patient, giving those providers visibility of what the patient does. Usually the patient gets away with a lot of things, and one of the good things that this program does is that works on behalf of the providers. So that's why at the end you truly see results not only in quality measurements, like lowering blood pressure and so on, but really reducing the risk and the cost.
Blue? Oh.
There you go.
Now that you say that, did you do a survey of the provider to see how providing him all this
Actually,
information?
we do. We have, Carlos, you want to answer that one? Or,
Sorry. Can you elaborate on your question? Sorry.
So, when I see this graph, I never, doing the study, you did all this research and information from the patient side. If I was a doctor and you are supporting me, providing me additional information that will help me alleviate some of the tasks or additional emergencies that I might have. I'm wondering if you asked the doctor
yeah.
what the benefits for him. If you want to expand, if you get that feedback from them, I think it would be instrumental.
Okay.
So I'm wondering if you did that or plan to do that.
Definitely. So each conversation with a potential client, or as we call them, partners, begins with an assessment. So we want to know what are the challenges that they face on a daily basis. When they share those challenges with us, that's how we develop our value proposition in terms of what our program can do, not only for their clinic, but for themselves, for their staff, and for their patients. One of the key takeaways, I'm not going to mention his name, but he is a nephrologist here in the island with 2 dialysis units, is that we we proved him wrong. That's how he mentioned it in a nutshell. He said, "You guys proved me wrong. I didn't think my patients would be able to use these digital technologies. I didn't think they would be engaged in the program. I didn't think that they would be answering calls that are not coming directly from the clinic. I didn't think they would be sharing information about their healthcare with someone other than their primary care provider, or in this case, the nephrologist." But the key takeaway from that experience, and also from our work with FQHCs here in the territory, is that it's possible, and that the rapport that our care managers develop with those patients allow us to gather even more data from them. So we have on one side the quantitative data from the devices, and then on the other side we have qualitative data from that patient that is reporting information and data points that were previously not in the EHR and were not being used for treatment options. So you have more visibility, more data points, both quantitative and qualitative, and you also have a better patient satisfaction and experience, which is another benefit that the providers are obtaining from this program.
Yes, and another provider, actually, he's a cardiologist. He loves the program because, as he says, this gives me visibility of what truly the patient does at home. And just right before the patient's gonna go to the visit, he gets to check all the points and everything. So now the patient knows that if the patient behaves bad, the doctor's gonna know. So one of the things that this provider told us is that, listen, I used to have patients with 3 and 4 medications just to lower their blood pressure, and just implementing or enrolling those patients in an RPM program, now those patients usually use 1 medication. So that is like a super win-win situation, not only for the patient, but for, of course, the provider, because at the end, we want to see people well and healthy and enjoying their life, especially if someone young. So the providers are very happy. I think the key ingredient is implementing this type of programs, just, having the whole team together from the beginning. Because once everybody really knows all the potential that these programs have, everything, is going to be secondary. So I think there are no more questions. So next slide. If you have any more questions, please visit our website at www.digimed.com, or you can shoot us an email, mara@digimed.com or carlos@digimed.com, and we will be more than happy to really help you and assist you, because like they say, it takes a village. It takes a village to implement new things, new ideas, and it takes a village to really see change. So thank you so much for the opportunity, and I guess we'll see you around. Thank you.